Okay, very warm welcome to everyone that's joining us this morning. We kindly ask that you'll just keep your microphone muted upon entry. And this morning we've got Silva Kuschke, who heads up our audiology department at Red Cross Children's War Memorial Hospital. So we're very excited to hear from Silva. So just to tell you a little bit about Silva, she's the chief audiologist and she heads up that audiology department, as I mentioned. This hospital, Red Cross War Memorial Children's Hospital, is the largest dedicated academic pediatric hospital in sub-Saharan Africa. She's also a joint staff member at the University of Cape Town. She loves working with children. She provides support to families with hearing impaired children. She enjoys clinical teaching and lecturing. Her particular interests are pediatric electrophysiology, as well as conducting context-specific research into childhood hearing loss in South Africa. And she's just completed her PhD in audiology at the University of Pretoria under the supervision of Prof. Devet Swanepoel. She's an avid classical pianist with favorite composers being Schubert and Beethoven. And overall, she's just a really nice, wonderful person. So, Silva, we're very, very excited to hear from you this morning. And yeah, we're excited to hear all about this topic. So I'll ask if I can hand over to you and you can actually share your screen for us.
Cool. Thank you so much, Louisa. And thank you so much for inviting me to present my research at your UCT-Africa online academic meeting this morning. I'm very excited about this research. It's still fresh in my memory. As Louisa said, I've just finished my PhD at the University of Pretoria, and this study that I'm going to present on this morning forms part of my broader PhD research that pertains to childhood hearing loss in the Western Cape province of South Africa. And I think the most salient point that I want to bring across today with this presentation is that we need to do good with what we have. We need to use what we have to provide the best possible services to our vulnerable children in low to mid-income countries. We cannot compare ourselves to high-income countries. We cannot use their protocols because we simply do not have the resources that they have. So we need to really think out of the box, and it's important to conduct context-specific research so that we can make plans with what is available to us in order to better serve our communities. This study was published last year in August in the African Journal of Primary Healthcare and Family Medicine. And I've just put the link to the DOI for you if you want to have a look at the full article. Throughout this presentation, I'm going to be using a lot of audiological acronyms. If it gets too much and you get lost, please stop me or just pop a message in the chat. I will try and see if I can address it as it pops up. Otherwise, if you have any questions, we can address them after the presentation. So childhood hearing loss really is an epidemic, and I'm not using that word lightly considering our current global context. But really it's a silent disability, and there's so much work to be done because globally 34 million children suffer from disabling hearing loss of more than 30 dB hearing level in either ear. Hearing loss is the second most prevalent developmental disability globally, and it affects around 15.5 million children under the age of 5 years. The burden of disease is very high in low to mid-income countries. So 95% of children with hearing loss reside in low to mid-income countries, as opposed to only 5% in high-income countries. We know that hearing healthcare services I'm going to just use LMICs throughout, otherwise we might be here for a while if I keep saying low to mid-income countries. So hearing healthcare services in LMICs are not prioritized by health systems that are overwhelmed by life-threatening diseases. And we know that there are a number of barriers to hearing healthcare, specifically in countries that are not well resourced, and these include a lack of access to hearing healthcare services, which means that patients often have to travel really far to access centralized services because there simply aren't services available that are close to their homes. This impacts on traveling distance, and if parents or caregivers have to travel far, often we see poor follow-up rates at follow-up appointments. There's also a lack of well-trained professionals, hearing healthcare professionals, and these include ENTs, speech therapists, and audiologists. And the latest research is still 1 hearing healthcare professional per 1 million children. So the burden on hearing healthcare professionals is really high. And I'm going to be talking about strategies of how we can address this later on in the presentation. So the rationale for this study, there's a growing burden of hearing loss. And we know from the World Hearing Report that was released last year, we know that by 2050, hearing loss is going to increase exponentially, with 1 in 4 people that will be suffering from hearing loss. So this growing burden in low to mid-income countries is disproportionate to the limited number of hearing healthcare professionals that are available. Current efforts to reach underserved communities are inadequate. There's limited primary level healthcare services in the Western Cape. So often services, primary level healthcare services like initial hearing screenings that should be done at a lower level of care, so at a primary level of care, and which certainly is more appropriate and would benefit the patient and the services at a centralized hospital. It leads to a situation where tertiary level hospitals are overburdened with services that could be done at a primary level care facility. So approaches that incorporate the delivery of community-based hearing care in order to decentralize hearing services is an absolute priority in our mix like South Africa. The objectives of this study was to compare a centralized tertiary model of hearing healthcare to a decentralized model through district hearing screening for the children in the Western Cape province of South Africa. So what happened is we created or pioneered an outreach clinic to a district hospital where we provided initial hearing screening to patients who were referred to our central children's hospital over a 7-month period. And we measured decentralization, or the effect of decentralizing hearing screening services by attendance rates, patient traveling distances, the number of referrals that we received at tertiary, if they were an outreach service versus if they weren't. And we also looked at the hearing outcomes of initial hearing screening, both at the district and at the tertiary level hospital. Our setting, the district hospital, was Victoria Hospital, which is situated in the South Peninsula Health District. And currently there are no audiology services at that hospital, which serves quite a big geographical area. The tertiary hospital in this study was Red Cross War Memorial Children's Hospital, which is situated in the Cape Town metropole. So as Louisa mentioned earlier, it is the largest dedicated pediatric hospital in sub-Saharan Africa. And we provide specialist hearing services at the audiology department for approximately 300 children per month. This includes screenings, diagnostic tests, intervention like hearing aids and rehabilitation. And both Victoria and Red Cross Children's Hospital are situated in an ALMIC, and it serves mostly children from the public healthcare sector who do not have access to medical insurance. So just to mention here as well, the public healthcare sector in South Africa serves approximately 85% of the population. So you can see here that public hospitals really carry the majority of the burden of hearing-related disease. In terms of the method, we had to jump through quite a couple of hoops to gain ethical approval because it was a Western Cape government study. So the study was approved by the University of Pretoria, the University of Cape Town, their research ethics committees, the Red Cross Ethics Committee, and then also the Western Cape Health Research Subdirectorate. And I just want to mention here, I think it's so important if we want to change something, and if we see that something is not working and we want to investigate a better, more streamlined process, I think it's so important to go through, the proper pathways and to get approval so that we can really effect change that's sustainable in the long term. In terms of our study design, we used a pragmatic quasi-experimental design with a 7-month control group where patients received standard care at the tertiary hospital, and this was June to December 2018. And then the second arm of the research was an intervention period where we offered hearing screening for children at the district hospital. So we took all our equipment, we organized a room, a really tiny room at Victoria Hospital, and we started doing the hearing screenings closer to the patient's home. And this was done exactly a year later, so June to December 2019. In terms of our sampling, we used consecutive sampling to select participants for both the tertiary and the district groups. Our tertiary group, a Red Cross group, comprised of 315 participants, and they were included based on a retrospective selection of all patients who were referred to Red Cross for the initial hearing screening from the district hospital catchment area, so from the Victoria, that South Peninsula area. And they came to Red Cross, and we selected them in the period of June to December 2018. And this was only for kids who needed initial hearing screening. So they've never had screening before, and they just needed a pass or a refer tick box to say their hearing is fine or they need additional testing. So the district group comprised of 158 participants, and this was a prospective arm to our study. So it was also consecutive sampling, and we selected referrals that were sent to Red Cross for initial hearing screening from the Victoria catchment area, but we only included referrals who met specific inclusion criteria for that intervention arm at the district hospital for screening. So I will talk a little bit more in detail about this later, but the method of screening was an otoacoustic emission, an OAE, and this particular assessment piece of equipment only tests the cochlear function. So it will miss retrocochlear pathology or anything happening along the hearing nerve, and it's also influenced by middle ear pathology. So patients who were known ENT patients who had middle ear disease, leaking ears, otorrhea, acute otitis media, wax, any of those, we rather referred them for diagnostic testing at Red Cross. And also patients who had risk factors for retrocochlear pathology or auditory neuropathy, such as patients who were born very prematurely or with low birth weight or with hyperbilirubinemia, so neonatal jaundice. Any of those patients were not included in the district group because of our screening method with the OAE. So the way that we collected data for the control period, we keep an audiology departmental database with quite detailed records here at Red Cross. And so we just did a retrospective review of that departmental database during the control period. So it had already happened during June to December 2018. And we looked at kiddies who had initial hearing screening. We looked at their demographic information, the reason for referral, their initial hearing screening results, so pass, fail, unilateral, bilateral. Then we looked at their diagnostic assessment results, and we also looked at the number of children from the district hospital area who were referred directly to the tertiary hospital, because there wasn't an outreach service at that point in time. For the intervention period, June to December 2019, we also utilized the same departmental database, and we looked back and calculated the number of children from the Victoria catchment area who were referred to us at Red Cross for initial hearing screening, but now while the intervention was ongoing, so June to December 2019. For the prospective data collection at Victoria during the outreach, we had a hearing screening data sheet that we developed that includes spaces for demographic information, geographical area of residence, the reason for referral, their OAE screening results, and then the need for further diagnostic testing. So still with data collection in the intervention period, patients who referred initial hearing screening either unilaterally or bilaterally underwent tympanometry on the same day at Victoria Hospital. And if we saw that there was anything in the middle ear, wax or a flat TIMP that could indicate, you know, a middle ear effusion, we referred them to the pediatrician at the district hospital on the same day. And then these children were rescreened at the district hospital after 2 weeks. And if they had another unilateral or bilateral refer result, we referred them for diagnostic testing at Red Cross. Okay, so it was one initial, one rescreen, and if they still referred their rescreen, they came to Red Cross for diagnostic testing. As I've mentioned, the equipment we used was a micro-Euroscan otoacoustic emission for initial hearing screening, and this was for the control and the intervention periods. It's a 4-frequency screener. It tests from 2 kilohertz to 5 kilohertz, and it's a low to high distortion product OAE protocol. It's fast, automatic, and it just shows a pass or refer result. The signal to noise ratio was 6 dB, and a pass result was obtained if 3 frequencies passed. Our data analysis, we captured all our data on a Microsoft Excel spreadsheet, and we analyzed it using SPSS version 24. Descriptive and inferential statistics were used because we were comparing 2 groups. So we used the Pearson chi-square test for categorical data, the student t-test for parametric numeric data, and a p-value of less than 0.05 was considered significant. Our results, when we look at the demographics, you can see that in the tertiary and district group, we did a p-value for all of the demographics just to show that the 2 groups were comparable in terms of age, gender, home language. So they were pretty much similar. The mean age for both groups was just over 4 years. And then the predominant languages that our patients spoke was English, and then Afrikaans and isiXhosa. The mean travel distance, I'll draw your attention to this, but we will also discuss it in a bit more detail. It's coming up. But just quickly, the mean traveling distance from the patient's home, and this is in kilometers, to the district hospital, so Victoria Hospital, where the outreach was taking place, was 12.6 kilometers. And the distance that these patients would have had to travel to the tertiary hospital based on their geographic area of residence was 19.1 kilometers. In terms of attendance rates, at the intervention or during the intervention period at the district hospital in 2019, we had an 83.2% attendance rate, which was significantly higher than the attendance rate of the control period group at the tertiary hospital 1 year earlier. So the control group's attendance rate was just over 70%. And when we compared the attendance rates for district and tertiary, we saw that there was significantly higher attendance at district. And it makes sense because it is closer to the parents' or caregivers' homes. When we look at the traveling distance, so to district, 12.6 to tertiary, 19.1. And when we compared those two, there was a significantly shorter traveling distance when patients had to travel to the district hospital. When we look at the number of referrals to a tertiary hospital, during the control period when children were seen for initial hearing screening at Red Cross, we received just over 1,700 referrals during those 7 months from the entire Western Cape province to our Red Cross hospital. So just over a quarter, 26% of those referrals were for initial hearing screening. So kids who've never had hearing screening from the district hospital catchment area. That's quite a large number of referrals, and you know, this just again supports the fact that there absolutely needs to be audiology services at a district level for a hospital who serves a very big catchment area. During the intervention period from June to December 2019, pretty much the same number of referrals were received from the entire Western Cape province, but only 7.1% of those referrals were for initial hearing screenings from the district catchment area. This makes sense because we were busy conducting outreach at the district hospital during that time. And so all those kids were seen at the district hospital and not at the tertiary hospital. So this resulted in a significant decrease in referrals to the tertiary hospital during that intervention period. Our p-value was very small. In terms of the reason for referral, this was for the 158 children who were included in the district hospital group. So we just had a look at why kids were referred for initial hearing screenings. You can see the speech delay was one of the predominant reasons, bacterial meningitis. If there were some behavioral school concerns, we had a few kiddies with autism spectrum disorder, some children with neurological risk factors. These included things like prematurity or epilepsy or anything neurological. And then you will see there's a large percentage or a large number of other referrals that we received that are put in here, but these children were not seen at Victoria. They were seen at Red Cross, and these included referrals for ear, nose and throat intervention if the children had risk factors for any retrocochlear pathology, genetic or syndromic head trauma or ototoxicity. These children would have been better served at Red Cross with diagnostic testing. So we excluded them. When we look at our hearing outcomes, this is now the hearing outcomes following the OAE screening, both at the tertiary group and for the district group. The first figure that I want to draw your attention to is the fact that on initial OAE screening, nearly 80% of children passed bilaterally at the tertiary hospital, and more than 80% passed bilaterally at the district hospital. So there really was no difference whether the screening was conducted at tertiary or district. The majority of children passed hearing screening bilaterally. Okay. Of those who referred either unilaterally or bilaterally and had to be re-screened after 2 weeks, nearly half of them passed bilaterally at the second screen. So it was either wax or something in the middle ear, or they were noisy on the day, and the majority passed if we just gave them 2 weeks and had a re-screen at the district hospital. Of the children who were referred for diagnostic testing at the tertiary hospital, nearly a third in both of the tertiary and district groups had normal hearing with their diagnostic result testing. So we see it often, especially children who've had a history of grommet and there's a little bit of scarring on the eardrum. Often an OAE doesn't pass just because of the, you know, the anatomy, shall I say, of the eardrum. But if we do a diagnostic test with proper insert earphones in a soundproof booth, nearly a third of them had normal hearing. And then the other results, diagnostic results for the rest of the children who had to have a diagnostic assessment, nearly half, again, in both the tertiary and the district group, had mild conductive hearing loss. And there was only one child that we identified with a unilateral sensory neural hearing loss that was profound at the district group. And then we also picked up one child who had a moderate conductive hearing loss at the district group, and one child with a moderate sensory neural hearing loss at the district group. So you can see really the majority of these kids had normal screens, and even in their diagnostic tests, it was just a mild conductive hearing loss predominantly. In terms of our discussion, I think, as I said in the beginning of the presentation, that the most important point here is that decentralization of really anything. It could be hearing screening, it could be vision screening, it could be TB screening in the communities. If we decentralize that, we will see an increased attendance at appointments, shorter traveling distances, and also decreased referrals, which will lessen the burdens on central tertiary level hospitals. We know that non-attendance in hearing test appointments delays the identification, diagnosis, and timeliest intervention of hearing loss, especially in low to mid-income countries. And this has such a snowball effect, because if children are identified late, their speech and language development will not be as good as a typically developing child, and they are at greater risk of poor academic performance, poor social interaction with others. And really, if they have a profound loss and they're identified really late and a lot of time goes by, it impedes the referral for cochlear implantation because of that auditory deprivation in the early stages of development. So the follow-up attendance for rescreens at the district hospital was really high, more than 80%. And I think this is because we did the second screen at community level as well. And we tried to coincide that appointment with a follow-up pediatrician visit if the child did have any middle ear effusions when we saw them for the first time. There was also a really high follow-up attendance rate of almost 90% found in a recent South African community-based study where rescreening was also performed at a community level. So I think that rescreen step in the process at district and the number of normal results that were obtained is really important to note. There are significant barriers to hearing healthcare in underserved communities, and these include access to hearing healthcare services and also the costs to attend healthcare appointments. And these include time taken off of work from the caregivers and also travel costs to attend the appointment with their child. So primary healthcare, and I cannot overstate this enough, primary healthcare is such an important strategy that needs to be employed in South Africa to provide more accessible patient-centered services that are closer to home. More than 80% of children passed initial hearing screening at the district hospital, and also almost 80% at tertiary passed the initial OAE screening. So really the hearing outcomes are similar for initial hearing screening, regardless of the level of care where the screening is conducted. District level screening increased access to medical treatment for children who were identified with middle ear pathology on our screening day. They were assessed and treated by the pediatrician on the same day instead of waiting for a really long time to get onto an ENT waiting list or to get an ENT appointment at a tertiary hospital. And we know that it's not just at Red Cross. It is everywhere, and it's not just for ENT. It's for all specialist services. So if we can decrease unnecessary referrals to centralized tertiary hospitals and have these children seen at a more appropriate level of care, it's a win-win situation for everyone. So middle ear pathology was treated timeously at a more appropriate level of care, and this decreased the added burden on long tertiary waiting lists. Limitations and future directions. So this was really a pilot outreach project. We wanted to see if it would work and if it would reduce the burden on our hospital and on our patients. So tertiary level audiologists conducted the hearing screening at the district level. But really, we should be training community healthcare workers and nurses to conduct the screening that we went to do at the district hospital. Task shifting is such an important premise because we need to use what we have. As I said in the beginning, we need to use our community workers and develop community-based hearing screening programs to improve access for our patients. Mobile health technology via home-based visits is also an important strategy to reach vulnerable communities in LMICs. And we need to reduce the demands on the very limited number, remember 1 per 1 million of hearing healthcare professionals in South Africa. And we need to empower our community healthcare workers to employ accessible strategies for hearing screening. In conclusion, decentralized hearing screening programs conducted at the appropriate level of care can increase access to hearing healthcare, reduce patient traveling distances and associated costs to the caregiver, and also reduce the burden on tertiary level hospitals. Accessible hearing screening leads to higher attendance and more time-yes intervention for children with hearing loss so that they can develop speech and language optimally. I would just like to thank all of the staff members at Victoria Hospital for their support and assistance during the study and for always being available, and also my colleagues at Red Cross who assisted me with data collection. Thank you so much.
Thank you so much, Silva. That was really fantastic. And I think everyone that knows you and knows your team and knows the Red Cross team know that you guys bang out a very large amount of work and that you work very hard and that you're very committed to child healthcare. I wanted to ask, we'll take some questions from the floor, but what I wanted to ask you is, Silva, in your opinion, what would be the sort of bare minimum requirements that you would need to be able to adequately screen kids at a primary healthcare. So let's say, for instance, I mean, this is maybe applicable to all over the country, and I'm sure in other countries in sub-Saharan Africa. What would you say would kind of be the very bare minimum requirements that you would need to be able to screen kids adequately in order to decentralize it? And then you sort of touched on this in terms of who could do it, you know, so it wouldn't necessarily need to be your ENT, because you've only got 1 per 1 million kind of persons in your country. So who could do it? And then do you think there's a role for kind of virtual liaison? In other words, could someone kind of screen them at primary healthcare situations and then have some sort of virtual liaison, a bit like we have here, where, you know, you could get in touch with someone virtually to reduce travel costs? I just thought, you know, I don't know if you can comment on that, what you think about that.
Cool, thanks, Louisa. Yeah, so I think the bare minimum at a primary level healthcare facility would definitely be, because I'm presuming you're going to see from newborn baby minimum geriatrics. And so I think it's important to have some objective and subjective equipment available. So at the bare minimum, a tympanometer, an OAE, an ABR, so the automated ABR for those babies who are at risk for retrocochlear pathology, which an OAE will not pick up. And then there are so many amazing advances in hearing screening technology. I'm just thinking about the Hear Screen. So it's a mobile technology on a cell phone, and there's an app, and all you need is supraoral headphones that's very good with cancelling out noise. So you don't even need a soundproof booth. The headphones are kind of your soundproof booth. So you would need a relatively quiet environment with those pieces of equipment, just to at least get a behavioral test or a behavioral result as well. And then I think the most important part, never mind the equipment, never mind who's going to be doing the screening, is project management. Because we have seen it so often where projects are started and the equipment is procured and the space is there and the person is employed and there isn't a data management system. So I think someone who is in charge of the hearing screening project, who can coordinate, who can flag children who've referred and refer them onto the appropriate place, you know, someone who is organized and dependable and has a data management system, so a cloud-based system where the information is shareable and accessible to everyone. So it's a transparent system. And then I really think that you need to have a well-trained screener. It can be anyone. It can be a nurse, although I know that nurses are so overburdened and so overwhelmed. It can be any community healthcare worker, as long as they are well-trained. And then, you know, it certainly doesn't have to be an audiologist or an ENT. I think what can also help is at primary healthcare level, there are a lot more speech therapists and OTs and physios that are typically based at primary level care centers. For some reason, the hearing healthcare is left behind. And so I think if the speech therapist is referred a child with a speech delay, instead of referring that child to a tertiary hospital for a screen, they can procure an OAE screener and test the child there and then and be done with a tick box. So I think it can be much more efficient and streamlined if we just get out of our heads that all kids need to come to a tertiary hospital for a hearing test. With the advance of technology and mobile technology, we can train community workers and even, you know, other allied healthcare professionals to conduct screening.
And Silva, just to follow up on that, so let's say people are interested in banging this up in their communities, how would you train someone like that? So what I mean is, where would they need to go? Or, you know, kind of how would they, so say I was interested in being trained for my community health center. Do I need to contact you, Red Cross, or is there, you know, how would you actually train someone that didn't necessarily come from an ENT or an audiological background?
Yeah, that's a really good question. So we are so happy to help and to train anyone who asks for help. I think, you know, we've offered a lot let me backtrack. I think it's important for whoever is going to do the training to actually go to the site and see what the setup is. So I do think it needs to be an audiologist who does the training, and please, anyone who wants to do this and who has equipment and who has permission to do screening at primary healthcare, just email me. We will go wherever we need to do the training. And it's not a huge thing, you know, but I think it's important to see the setup, to see the ambient noise levels in the space, to have a proper screening protocol, you know, not just to do, say, a year test without any TIMPs or any OAEs, and just kind of train the person in seeing all the parts of the picture and not just then referring to tertiary if one frequency fails. So I think a needs analysis of the situation where you're going to do the screening is important, and all of us here at Red Cross are super happy to train anyone and everyone.
And if there are other countries that are interested, are you happy for them to just liaise with you as a backup?
Absolutely. We can also set up like a virtual call, a Zoom or a Teams or whatever, and we can have a talk through it and set up some testing protocols and referral pathways.
Thanks, Silva, you're an absolute superstar. I just want to open it up to the floor and find out if there's any questions from the floor. Anyone else that's attending the meeting, if you wouldn't mind to just raise your hand or just give Silva a shout out.
Can Ilse make a comment? Ilse?
Good morning, Silva. Thank you very much for a great talk. I think, so 3 things. I think when it looks at the stats, you think probably between 12 and 19 kilometers. I mean, what is 7 kilometers? But it probably is like 2 or 3 extra taxis that they've got to take. So I am the ENT at Victoria, and we often say, just go to that hospital, and you can literally see how the people say, but how? So it probably adds like 5 hours to their day because they've got to have 3 extra taxi stops. So although I'm sure for people from Africa, you think, well, what is the difference? It's just 7 kilometers. But, you know, it's extra 5 hours and it's a huge cost. I think a program like this needs 2 things, and that's what Red Cross got right very well, is it needs to have an easy referral system. So Red Cross works on emails and they work on an app. So it's easy to get the patients, and we know that they are going to be seen. If you refer a Red Cross audiology patient, we know that they will be seen and they will come back to us with audio. And I think the other very important thing is, if you want to have a district hospital screening system, there must be a follow-up. So we have an amazing pediatric system, and Red Cross, whenever they flag someone, so I am there on a Tuesday morning. There's Emma that has been running that program, that is the ENT there for many years, and I'm there just on a Tuesday morning. But you can't just screen. And the one thing that Red Cross Audiology got right very good, and the pediatric department, is whenever we flag somebody and there is a hearing loss, they will email me and say there isn't a follow-up appointment for this patient, or the pediatric department, I see Jill is on the call, they would literally walk across and say, you don't have a follow-up. You arrange the screening, but the balls often get dropped. And I think the nice thing about their system is they make sure the patients don't get dropped. They email me and then email me twice and say, when are you going to see the patient? Or the pediatric department will walk over and say, when are you going to see the patient? Because I think if you want to screen, you can't just have a screening thing. And I think that's what Silva is very important. You can't just set up a system. You must make sure that something happens to those patients. You know, when they get screened, that we actually act on what we find. But I fully agree, there's definitely a need to screen them, because hearing loss is a problem. And I think especially in our education system, where there are 40 kids in a class, we can't afford those kids not being able to hear. That's why it is such an important system to make sure that we screen them, and quickly.
Wonderful, thank you, Esty. Are there any, Silva, do you have any comments or any sort of reply to anything that Esty said?
No, I fully agree. Yeah, I think it's so good to have, that to have an ENT service there for sure. I think the next step is an audiology service right there at Victoria. I believe they are doing some fundraising now for a new and improved pediatric outpatient department there at Victoria. Hopefully that includes a booth. I'm being very presumptuous here now.
Silva, could I ask, what's the role of teachers in terms of screening, especially with the new mobile devices that's been developed by the It's wonderful?
Yeah, I think that's another area of very important research, training teachers to conduct screening at schools. I think it's very relevant, and I think it could be done because we do get a lot of referrals based on teacher concern. In the classroom, the child's not responding, or you have to repeat instructions a few times, or they're not listening, and so the teacher is the person who sees those concerns. And often it's not the hearing, often it's something else, like an attention deficit thing, or some underlying learning disability. And I think if a teacher has one of those ear screen apps right then and there during break time, they can quickly screen that child, document in the child's notes at school that this child's hearing is fine. Because we often see, all those referrals that we had for school/behavioral concerns, the majority of those children don't have hearing loss. They pass their hearing screening. And so if we can eliminate that extra step of them having to come for hearing screening when it could be done at school, I think that could be brilliant. That could be another screening area where children can access hearing screening.
It could be another PhD, am I right?
No, thank you, I'm done.
The other issue I've raised is I think it's very important to follow up a study like this with a public campaign. So you have to get this, you have to put pressure on the politicians and the health services. And so I would suggest that you go to Cape Talk and radio stations, and that you really get on the air and you share this. And get Esty to help you to write for Roy Worcester and for all the other magazines, which are important because this is what people read, and it does influence public opinion. And so I really would urge you to do that if you want to get things changed.
Thank you so much. I think that's a great suggestion.
Silva, have you got your email address somewhere on your PowerPoint presentation?
I do not. I can give
it
it to you guys quickly. Let me see if I can I'll quickly type it in the chat, Louisa. Let me just quickly type it in here. So it's silva.kuschke@westerncape.gov.za. I've just put it in the chat now.
Wonderful, thank you. Silva, as always, absolute pleasure. We appreciate what you do. And yeah, you're very well loved at Red Cross, and we know you guys work very hard. And thanks so much for making the time, and we'll definitely invite you back.
Thanks so much for having me. Have a nice Friday, guys.
Thanks, everyone. I'm going to end the meeting. I don't see any more comments except from Jill saying thanks very much, Silva.
Someone I used to write for the baby and